Good morning, everyone. I am Dr. Sonali from Pediatrics, and I will be presenting a case from Pediatric Emergency and Critical Care Unit. We have Master H, 3-year, 8-month-old boy, resident of Sonipat, Haryana, who was admitted to us on 27th of January 2023, discharged on 1st of February 2023 with PGI hospital stay of 5 days. Child presented to us with complaints of intermittent cough for 12 days and generalized body swelling for the last 4 days. On 16th of January 2023, the parents noticed sudden onset of dry cough followed by left-sided neck swelling. It was non-paroxysmal, not associated with post-acid vomiting. No noisy breathing, positional or diurnal variation was there. There was no history of trauma, witness choking, noisy breathing, cyanosis, insect bite, previous nebulizations, decreased urine output, increased precordial activity, recurrent LRTR or poor weight gain. Following this episode, child was taken to a private hospital, and following this, a chest X-ray was done. We can clearly see that left side is hyperinflated with mediastinal shift to the right, and some degree of subcutaneous emphysema can be seen. This child was treated as a case of pneumonia and received IV antibiotics for 5 days outside with no oxygen support, following which the child completely improved. On 21st of January, child was discharged, and between 21st to 24th, the child was asymptomatic. Again on 24th of January, child had sudden onset of dry cough, following which there was a painless neck swelling. Following this, the child was again taken to the private hospital, where this chest X-ray was done. The left side was wrongly marked as right, and as we had previously seen, there was left-sided hyperlucency, which was seen on the right side as the marking was wrong, and the clinician interpreted it as pneumothorax, and right-sided ICDT was inserted. Following which, the swelling progressed from the face to trunk to bilateral limbs and genitals over the next 3 days. On 27th of January, the child was admitted to us on APC emergency. There was no significant past history. Antenatal history was unremarkable. Child was a term-born normal vaginal delivery, 3.2 kg, appropriate for gestational age, cried immediately after birth. Child was immunized and developmentally normal. On 27th, on our triage, on assessment pentagon, the airway was open and stable. Respiratory rate was 30 per minute with increased work of breathing, with saturation of 95% on room air. There was differential air entry, right more than left, and crunching sounds were present all over the chest. Child had a heart rate of 102 per minute, with CFT of 2 seconds, with good peripheral and central pulses, and ECG was sinus rhythm. Had a GCS of 15/15, with normal CNS examination, with euglycemia, and on exposure, child had generalized subcutaneous emphysema, involving the face, the neck, the trunk, and the lower limbs also. And right ICDT was in situ. Our physiological classification was level 2 emergent with respiratory distress. On focused examination on anthropometric parameters, child had weight of -1.52 z-score and height of -1.25 z-score. There was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy, but generalized subcutaneous emphysema as described was present. Other system examination was normal, but there was differential air entry with right more than left and subcutaneous emphysema over the chest and abdomen. These pictures were taken with consent, and we can see the generalized subcutaneous emphysema involving the whole of the face, the neck, the trunk, and the limbs also. So we have a 3-year-old, 8-month-old boy who was previously normal, presented to us with sudden cough, followed by neck swelling, with a 48-hour period of normalcy, with repeated episode of sudden onset cough and generalized body swelling, with difficulty in breathing. Our examination findings were respiratory distress, differential air entry, and generalized subcutaneous emphysema. So our provisional diagnosis was spontaneous subcutaneous emphysema, most likely due to an airway foreign body or necrotizing pneumonia with air leak. This was our admission chest X-ray at PGI. We can see that there is left lung hyperinflation. The mediastinum has been shifted to the right. There is some degree of pneumomediastinum. Right ICDT can be seen in the subcutaneous tissue, and generalized subcutaneous emphysema, which has increased a lot from the last X-ray, can be appreciated. Also, there is right-sided pneumonia. So there was very high suspicion of foreign body in the left main bronchus, following which a CECT test was done, and a well-defined hyperdense endoluminal structure in the left main bronchus at the level of bifurcation with hyperinflated left lung, most likely a foreign body, was seen. We can see that the mediastinum has been shifted to the right. There is right lower lobe consolidation and layers of hypodensity in the chest wall indicating surgical emphysema. Also hypodense layer in the mediastinum suggesting a mediastinum. And there is consolidation of the right lower lobe. So, for our management, for the respiratory distress, child was started on nasal prong oxygen at 3 liters per minute, and ceftriaxone and cloxacillin was started for the pneumonia. Since there was very high suspicion of foreign body, an urgent rigid bronchoscopy by the pediatric surgery team was done, and edematous vocal cords with a foreign body in the left main bronchus, occluding the lumen, were seen, which was a peanut, and they were not able to even remove it as a whole. It was removed in pieces. Following which the child was shifted to our intensive care unit and was ventilated on PSIMV mode of ventilation with tidal volume of 5 to 6 ml per kg with PEEP of 5. Child was extubated on day of admission 3 and kept on nasal bronchs, and day of admission 4 the child was made on room air. Following the removal of foreign body, the air leak had resolved. This is our endoscopic image. We are right now in the trachea. We are in the right main bronchus. As we can see, 2 openings. It is clear. And now we are in the left main bronchus, where we can see this hygroscopic structure, which is almost completely occluding the left main bronchus. This is the image of the child post foreign body removal and the chest X-ray, and we can see that the air leak has resolved on the X-ray as well as clinically. So our unit's final diagnosis was foreign body peanut in the left main bronchus with obstructive emphysema, with tracheobronchial injury and air leak syndrome. So when should we suspect an airway foreign body? When we have a history of witnessed foreign body aspiration, a sudden onset of cough, choking, noisy breathing, breathlessness, cyanosis, hoarseness or drooling, and usually there is a symptom-free interval because of the adaptation. On examination, we can find wheezing, stridor, unilateral reduced air entry or subcutaneous emphysema. Under radiology, we can see unilateral hyperinflation, atelectasis, mediastinal shift, air leak, infiltrates, and if the foreign body is radiopaque, it can be seen in 8 to 10% of the cases. So in our index case, we had a sudden onset of cough, we had a symptom-free interval, we had unilateral reduced air entry, we had subcutaneous emphysema, we had unilateral hyperinflation, atelectasis, air leak, and infiltrates. So the learning highlights of this case is why was the diagnosis of foreign body often gets missed? What should be our approach to a child presenting with subcutaneous emphysema? Airway foreign body as a cause of isolated subcutaneous emphysema. What were the factors that aggravated that subcutaneous emphysema? When to put the ICDT? Pneumothorax versus obstructive emphysema, and role of CT scan in aiding the diagnosis. So 0.6 to 1% of admissions in pediatric emergency with age group of 6 months to 5 years peak at 1 to 2 years account to airway foreign bodies, and all the literature worldwide has suggested a male preponderance of around 60 to 70%. Most common objects are peanuts and other vegetative food items, and most common site, there is an equal divergence of bronchi from tracheal axis in less than 5 years is right main bronchus, and least common site is larynx. There was a study in Japan for diagnostic errors in initial misdiagnosis of foreign body in China, where out of 246 patients, 72 cases, accounting to more than 1/3 of the children with foreign body aspiration, were missed at the first presentation, and errors in diagnostic testing and history taking were the leading causes. History misinterpretation in 43.8% cases, and errors in physical examination in 32.5% cases. And there was over-evaluation of competing diagnoses in 51% cases, like pneumonia and bronchiolitis. So good history in a foreign body aspiration setting in a child of 6 months to 5 years of age with sudden onset of cough and a typical history can decrease the chance of missing a foreign body. Common clinical features can be cough in 71%, breathlessness in 47%, fever in 43%, unilateral decreased air entry in 64%, respiratory symptoms and wheeze in 30%, and obstructive emphysema in 56%. A normal chest X-ray can be seen in 8% and up to 20% has also been reported. But subcutaneous emphysema and pneumomediastinum without pneumothorax, which was our index case, is very uncommon and very few case reports have been published. So how does foreign body causes subcutaneous emphysema? If there is complete obstruction of bronchus, it will cause a stop valve effect, which will lead to complete atelectasis. But if it is partial obstruction, it will cause a ball valve or check valve effect. During inspiration, the air will go in, the alveoli will be inflated, but during expiration, there is a block, leading to air trapping, causing lobar or the lung emphysema. That emphysema will lead to air leak as alveolus will rupture, and along the bronchovascular plane, the air will move towards the mediastinum. As mediastinal pressure increases, decompression may occur in subcutaneous or cervical spaces. Subcutaneous emphysema needs to be differentiated from allergic reactions and angioedema. There will be no crepitus in angioedema, and subcutaneous emphysema is lip sparing. Other causes can be trauma, surgical and laparoscopic procedures, asthmatic attack, and tracheal injury during intubation. For management, we need to treat the underlying cause. Mild subcutaneous emphysema can be observed with high concentration oxygen, but if it is causing hemodynamic compromise or airway obstruction and is extensive, a 2 centimeter infraclavicular incision to reduce the expansion can be done. A subcutaneous drain superficial to the pectoralis fascia with low suction can be placed, and for ventilation, low tidal volume and low PEEP strategy should be taken. Invasive therapy is only done if there is airway or hemodynamic compromise. For ventilation in air leaks, low peak inspiratory pressures and low PEEP with low tidal volumes with permissive hypercapnia and hypoxemia should be targeted, and we should target low plateau pressures and driving pressures. What are the factors that aggravate the subcutaneous emphysema? Any change which causes increase in airway pressure, like irritability, paroxysmal coughing, or positive pressure ventilation, or in our case, the insertion of wrong ICDT, aggravated that subcutaneous emphysema. And how to differentiate this obstructive emphysema from pneumothorax? We can see that in obstructive emphysema, there is radiolucency, but vascular shadows are still there. But the pneumothorax X-ray shows completely radiolucent with no vascular shadows at all. And most important differentiation is the pleural line and the collapsed lung, which is seen in pneumothorax. CT is not routinely indicated in airway foreign body. It can be done in a forgotten foreign body, or if there is a suspicion of residual foreign body after bronchoscopy. But recent studies have suggested that CT scan with rare airway reconstruction can accurately and quickly detect airway foreign bodies and reduce the chances of negative bronchoscopy. Our own study in PGI in our radiology department showed that excellent positive correlation between CT virtual bronchoscopy with bronchoscopy and surgery for evaluating bronchial stenosis caused both by endoluminal and extraluminal obstruction, and we can see beyond the foreign body, like what is the pathology happening. So for management of foreign body, we need to assess airway breathing and circulation, start the child on oxygen, examine oral cavity and throat, and antibiotics if infection is suspected. And the first thing, which is our main in diagnosis, is chest X-ray. If it shows unilateral hyperinflation, atelectasis, and unexplained air leaks, we should directly go to rigid bronchoscopy for foreign body removal. But if there is a normal chest X-ray, which can be there in 20% of cases also, but history is very definitive, then also we should go for rigid bronchoscopy. If the history and chest X-ray are inconclusive and low suspicion is there, then we can follow. Then we can keep a low threshold for bronchoscopy. For prevention of foreign bodies in children, we need, which is the main take-home message, that children less than 5 years should not be given foods that make them choke like nuts, to avoid hard foods, to emphasize the need of cutting soft and round foods lengthwise before serving, to avoid making children laugh or cry while eating, to teach children when to eat while seated only, to follow the age recommendations printed in the packaging of toys, and to remind that any broken toys should be discarded. These are the take-home messages from our unit, that high index of suspicion of airway foreign body should be kept in hyperacute or unusual respiratory presentations. The classical triad may not be present in all of sudden cough, wheeze, and differential air entry. With unexplained air leaks, we should suspect in foreign body. Rigid bronchoscopy is the gold standard, and early identification and removal leads to complete cure. And most importantly, to read our X-rays carefully, and clinical confirmation is must before doing any invasive procedure.
Thank you, Dr. Sonali. Please join me.